Now, we are going to continue by looking a bit more closely at the drug-receptor interaction in terms of agonist drugs and antagonist drugs. These little figures down the bottom are just little snips from videos that I made previously, and I've placed these in the supplementary resources in the topic. So, you know, once you've gone through these recordings, you're still a bit unclear about agonists and antagonists and other things, have a look at them and see if it makes it even more clear. Okay, so occupation of a receptor by a drug molecule may or may not result in the activation of the receptor. Activation means that the receptor is affected by the bound molecule, so by the drug molecule, in such a way as to elicit or produce some sort of a tissue response. Binding and activation then represent two distinct steps in the generation of the receptor-mediated response by the agonist. Okay, if a drug binds to the receptor without causing activation and thereby prevents the agonist from binding, it is termed a receptor antagonist. Okay, so here down the bottom you can see it, and not drawn to size by the way, I've just drawn a plasma membrane. And we've got this transmembrane protein here with a receptor binding site here, and our agonist in green binds to it, and I've just indicated there the activation by that star turning yellow. Okay, with the antagonist it still binds to the same site here, but it doesn't activate it, and that's indicated by the star staying that grey colour. So the tendency then of a drug to bind to the receptor is governed by its affinity, whereas the tendency for it once bound to activate the receptor is denoted by its efficacy, right? Drugs of high potency generally have a higher affinity for the receptor and therefore occupy a significant proportion of the receptors even at low concentrations. Agonists also possess significant efficacy, whereas antagonists in the simplest case have zero efficacy, right? So agonists display affinity and efficacy, the ability to produce a tissue response. Antagonists display affinity but have no efficacy, and that's why they're used as blockers to block the endogenous ligand from binding. And so an example then of an antagonist is naloxone, and naloxone blocks the opioid receptor, and it's used to sort of reverse the harmful effects of an excess of opioids, such as what occurs when somebody has a heroin overdose. And so just to summarize this then, an agonist activates a receptor. While bound, it takes the place of the endogenous substance. So it's mimicking the effects of the endogenous substance, whether that's growth hormone or thyroid hormone or adrenaline or some a cytokine or something else. It displays affinity, so a tendency to bind to the receptor, and efficacy then, a tendency to activate the receptor. An antagonist then limits the activity of the receptor. So while bound to the receptor, it blocks the endogenous substance, so the endogenous ligand, from binding to the receptor. So it doesn't produce an action by itself. And the example that we've given you here is a beta blocker versus an alpha adrenergic receptor agonist. Now, you don't need to know the details of this at this stage, but a beta blocker, of course, is a drug that binds to the beta adrenergic receptor to block the effects of adrenaline in the heart. So that's going to cause the heart rate to slow down and also the heart to beat with less force. Whereas an alpha adrenergic receptor agonist mimics the effects of the sympathetic nervous system. So it's mimicking the effects of adrenaline and noradrenaline. We'll go back to this familiar diagram here, and you can see very clearly from it that drugs with intermediate levels of efficacy, such that even when 100% of the receptors are occupied, the tissue response is submaximal, are known as partial agonists. And in contrast, the full agonists can elicit or produce a maximal tissue response. So very clearly here you can see drug A is the full agonist, drug B is a partial agonist, and drug C, of course, is a partial agonist as well. And this little one here, C, is doing very little in terms of generating, a tissue response, that it might be even used as a competitive antagonist. And if you don't get that yet, you will in a few slides' time. And to summarize this then, the ability of a drug to activate the receptor is graded rather than following sort of an all or none rule. Full agonists induce maximal response when all receptors are occupied, and partial agonists can only ever produce submaximal response even when all of the receptors are occupied. So the difference then between the full and the partial agonists is the efficacy. And so if we look at these partial agonists and efficacy here, and what we're looking at here are 5 different alpha adrenergic agonists. You don't need to know the names of these drugs here, but you can see the purple one is phenylephrine, which is the full agonist. And then we have these sort of 4 partial agonists here that with different, efficacies themselves, so different abilities to induce a tissue response. And you can see telazoline down here, which is this pale pink one, is not really doing much at all, but because it's it is producing this dose response curve slightly, it's still classified as a partial agonist because it is activating the receptor slightly. And then if we look at it relative to the fraction of receptors occupied, you can see that, even when 100% of the receptors are occupied, none of these partial agonists, can elicit or produce the same tissue response that this full agonist is producing. And moving on now to antagonistic drugs. Firstly, we have reversible ones. These are antagonistic drugs that bind reversibly to the receptor, and while bound to the receptor, inhibit its activity. With these reversible antagonistic drugs, it's the formation of hydrogen bonds between the receptor molecules and also the drug molecules. So that electrostatic force that holds them close together. But what you have to remember is, that hydrogen bonds are weak bonds. They're always being formed and broken and formed and broken. So what happens is, the drug molecule binds to the receptor and then it dissociates off and then binds again and dissociates off. So it's very dynamic. And this is why an increased concentration of endogenous ligand there is required to stimulate the same effect. Now, again, if you don't get this yet, we will talk about it in a little bit more detail later on. But it's like the antagonistic drug is competing with the endogenous ligand. And while it's bound to the receptor, it inhibits its activity. But because the bonds between the target receptor and the drug molecules are weak, an increased concentration of the endogenous ligand will sort of overcome the effect of the antagonistic drug. Now, on the other hand, with irreversible antagonistic drugs, the drug dissociates from the receptor very slowly or not at all. And the drug will continue to block the endogenous ligand's activity until the bound receptors are replaced. So the bound receptors are taken into the cell and replaced with fresh receptors. And this is because of the formation of covalent bonds between the drug molecules and the receptor molecules. And we know that these are very strong bonds. I'll just summarize these dose response curves, but if you are completely all over this, you can just skip to the end. Okay, I'm just going to point out a few things for you to think about and bring any questions that you have to your tutorials. You can have drugs with the same efficacy, but different potencies. And you can see that reflected here. We have 3 full agonists. So they are all producing the maximal tissue response, but you can very clearly see there that drug A is the most potent. It's 3 times more potent than drug B, which is 5 times more potent than drug C, making drug C the least potent. So most potent meaning it's going to produce a response at a lower concentration, right? Now, we also talked about agonist drugs in terms of partial agonists. And here we have the 3 partial agonists, and you can have agonists then with different, efficacies, but, the same potency. And I won't go into that again. If you're still struggling with that, go back and view the previous recording. Okay. What I do want to talk about here is, in a little bit more detail, there is a concentration of drug that's going to give you the subtherapeutic effect. So it wouldn't be prescribed at that dose because it wouldn't be of any benefit to somebody if it's a subtherapeutic effect. Then you can see this linear part of all of these dose response curves that will give the therapeutic effect. And that's anywhere sort of from a 20% to an 80% tissue response. Now, keep in mind, that there is variability in responses to drugs. So, these are the concentrations that a clinician will prescribe to give you that therapeutic effect. You can also see that there's a plateau part of these dose response curves. And really and truly, like, as you increase the dose there, you're not really getting any more of a benefit in terms of a tissue response, and you do increase the risk of adverse reactions. And again, that's partly maybe due to your genetics or your age, or you might have somebody who's taking multiple drugs, and the polypharmacy issue is causing drug interactions between a couple of these drugs. And some drug interactions occur where one drug will kind of amplify the effect of another drug. And in that case, it can, increase the risk of adverse reactions, including toxicity. Okay, so I have now finished this part of the topic. When I come back, I'm going to be talking about desensitization, or you might know it as tolerance. There's slightly difference between them, but you can also use this summary slide just to really consolidate your learning of what we've done so far. So I'll see you all soon.